Good morning. I am Serena Bugatti and I am Professor of Rheumatology at the University of Pavia in Italy. And I really thank you for giving me the opportunity to give you this talk and share with you some ideas on the mystery of seronegative rheumatoid arthritis. These are my disclosures. So during this talk, we will try to see what is the extent of the problem in seronegative rheumatoid arthritis, but probably the most important question is whether it exists. Is its pathogenesis different from that of autoantibody positive rheumatoid arthritis? And provided that it exists, are we able to diagnose the disease early? Are we able to treat? And are we able to measure the outcomes in this subset of the disease? So as you see here, this is a chart I published last year summarizing the frequencies of seronegative rheumatoid arthritis in different background populations, intending by seronegative negativity for both rheumatoid factor and the anti-citrullinated protein antibodies, showing that in cohorts of established rheumatoid arthritis coming from registries of biological therapies, the frequency of seronegative patients is approximately 20, 25, 30% as maximum, but at the bottom of the table you see the frequency of seronegative rheumatoid arthritis in the context of early arthritis clinics, so in early disease. Here you see that the prevalence grows a lot, up to 50% according to data from different cohorts, including ours in Pavia. And we know that the incidence and the prevalence of seronegative polyarthritis and seronegative rheumatoid arthritis is progressively increasing over the years. These are data coming from the American experience and confirmed by the Leiden Early Arthritis Clinic, showing that the incidence of seronegative forms is increasing, and the authors attributed these secular changes to changes in lifestyle risk factors, including reduction in smoking habits, and we know that smoking is strongly associated particularly to the development of seropositive rheumatoid arthritis, and also to reduce in bone in body mass index and lifestyle factors in general. But despite the fact that we have advanced a lot, our knowledge on the pathogenesis, early recognition and treatment and targeting of autoantibody positive rheumatoid arthritis, we see here that the outcomes of autoantibody negative rheumatoid arthritis are not improving equally compared to the autoantibody positive forms. These are gain data coming from the Leiden Early Arthritis Clinic, showing the long-term 10 years observation of patients stratified for the presence of the anti-citrullinated protein antibodies. And we see here that it is true the frequency of drug-free remission, so remission that can be sustained in the absence of treatments, is increasing in autoantibody negative rheumatoid arthritis, but not equally the prevalence of well control of patient-reported outcome measures, physical function. So patients with seronegative rheumatoid arthritis continue to experience, despite advances in treatment, continues to experience significant worse outcomes in terms especially of health-related well-being, health assessment questionnaire, persistent pain, persistent fatigue, and persistent disability. So the outcomes of seronegative rheumatoid arthritis are still unfortunate. But the problem is, does it exist? Do we know what is seronegative rheumatoid arthritis? Of course, this is a diagnosis of exclusion, And we might also suspect that some misdiagnoses exist when we label a disease as seronegative. Here again is the graphical view of the possible overlaps of seronegative and seropositive forms and the possible mimickers of a polyarthritis. And in particular, we know and we must mention that it is entirely possible that we are actually missing the detection of some autoantibody systems and some autoantibody forms in a subset of patients that we defined being seronegative for rheumatoid factor and the anti-citrullinated protein antibodies. We know that there are other AMPA, so other anti-modifying protein antibodies that have been recognized in the past 15 years, including the anticarbamylate proteins that partially overlap, of course, with the ACCP response. So it is true that the majority of CAR-P reactivity is found in overlap with positivity for the anti-citrullinated protein antibodies, but different works have shown that isolated positivity for the CAR-P can be detected in approximately 10–15% of the patients that we consider to be seronegative upon the classical and routinely assessed autoantibodies, so the rheumatoid factor and the ACCP. So it is possible that a small proportion of what we call autoantibody negative rheumatoid arthritis is in fact seropositive according to other antibody specificities. Another big problem is that we can misdiagnose some forms of seronegative rheumatoid arthritis that in fact in time are recognized as being more properly labeled as the spondyloarthritis. These are data from the Finnish registry on the left part of the slide, showing that in a 10–14 years time frame, up to 10–15% of the patients who were labeled as seronegative rheumatoid arthritis do in fact develop some elements that move them into the diagnosis of the spondyloarthritis, particularly psoriatic arthritis, when skin psoriasis starts after the onset of symptoms. And on the right part of the slide, there is a small Italian experience showing that when we look into more details into the sign of skin psoriasis in patients with early seronegative polyarthritis, we can in fact, with the help also of joint ultrasonography, we can find some signs of unrecognized skin psoriasis. So it is entirely possible that a proportion of the patients that we call seronegative rheumatoid arthritis in fact suffers from a spondyloarthritis. So again, we can erode another, let's say, 10% from the group of the seronegative rheumatoid arthritis. Another big mimicker are the crystal arthropathies, in particular calcium deposition disease. And in fact, again, it has been recognized that upon a careful re-evaluation of the conventional X-rays of the hands, up to 5% of the patients that were labeled as seronegative rheumatoid arthritis do in fact have signs of calcium deposition disease. It is not possible to say whether these two disease entities coexist, so if the patient has both rheumatoid arthritis or the CCPD, but in fact these seronegative patients might have signs of CCPD and thus can be relabeled as suffering from a chronic crystal arthropathy. But still, even if we accept that we can have misunderstood and misdiagnosed some forms of seronegative rheumatoid arthritis, still we do have at least 20–30% of the patients that classify as rheumatoid arthritis in the absence of autoantibodies and their diagnosis cannot be explained by other differential diagnoses. So we do have a disease entity that is completely seronegative. And unfortunately, research is very difficult and slow in this field, and whereas we perfectly know nowadays what are the genetic background, the pathophysiological mechanisms upon the development of the seropositive forms of rheumatoid arthritis, particularly we perfectly know all the history of the development of the anti-citrullinated protein antibodies, the development of ACPA-positive arthralgia, and then the evolution into arthritis. We do not know anything about the pathogenesis and clinical history of seronegative rheumatoid arthritis. From the literature, again, we can assume that the genetic background is different, so we do not have the classic alleles into the DR molecule MHC2 antigen presentation site shared with seropositive rheumatoid arthritis. So the genetic background is different, and also possibly the pathophysiological events. So there is a much lower role, for instance, of smoking that is not recognized as being a risk factor for the development of seronegative rheumatoid arthritis. Much more important are hormonal factors. We know that the peak incidence age of seronegative forms is a little bit delayed compared to that of the seropositive forms, especially in women. So around menopause and immediately after menopause, presuming that hormonal factors are important. We might suspect that some infectious or commensal agents might also play a role, but probably what we know better is that the pathophysiology is different. We know that the seropositive forms are predominantly driven by T-B cell interactions with T-cell, B-cell help provided by the follicular T helper cells that induce germinal center reactions and the production of autoantibodies. And we know that this type of immunity is mostly lacking in seronegative rheumatoid arthritis, where we predominantly recognize either innate immune response or a CD8 T cell centered pathology, very similar to that occurring in psoriatic arthritis and in other forms of seronegative polyarthritis. And in fact, this is a study comparing the synovial histology we performed a couple of years ago, comparing the synovial histology of seropositive rheumatoid arthritis versus seronegative rheumatoid arthritis versus psoriatic arthritis, both the polyarticular and the oligoarticular forms. And you see here that the degree of adaptive immune infiltration as expressed by the extent of B-cell infiltration of the synovial membrane is highest in seropositive rheumatoid arthritis, and in seronegative rheumatoid arthritis very much fits and compares and coincides with that of psoriatic arthritis. So B cells are less represented in the synovia of patients with seronegative rheumatoid arthritis compared to those of seropositive rheumatoid arthritis, and the histopathologic picture and pattern very much resembles that of psoriatic arthritis. And also serum biomarkers reflecting B cell activity, for instance the chemokine CXCL13, which recruits B cells into the germinal center and thus express germinal center activity and a lot of activation of B cell. Levels of this chemokine are higher in seropositive rheumatoid arthritis and much lower in seronegative rheumatoid arthritis, again overlapping the levels seen in psoriatic arthritis. This is all we know about the pathogenesis and of course research is encouraged because we are pretty convinced that the mechanism differ from those of seropositive rheumatoid arthritis, and we have to look into the disease path in order to better diagnose and better treat through target therapies. The seronegative forms of rheumatoid arthritis are very unfortunate also for their clinical picture and clinical history. These are data coming from our early arthritis clinic experience. So in Pavia, we do have an early arthritis clinic since 2005, and we see patients referred for suspect inflammatory arthritis of short duration, less than 12 months. And then when we diagnose rheumatoid arthritis upon careful clinical laboratory and imaging examination, we follow this patient up according to treat to target and tightly controlled treatment strategies. But these are only data referring to time zero, so to patient enrollment to our early arthritis clinic. And you see here that comparing the path and the natural history we have seen over the years in seropositive rheumatoid arthritis, in which basically the diagnostic delay has remained rather stable and the disease is becoming milder, both in terms of the burden of inflammatory activity, so the swollen joint count, CRP levels, so are progressively decreasing over the years, with maintenance of a delay in recognition, which is quite stable over the years. You see here on the bottom part of the slide that the delay in seronegative rheumatoid arthritis is increasing, so fewer patients are recognized within the window of opportunity. The patients that have access to the early arthritis clinic earlier are those more inflammatory, but the less inflammatory forms remain undetected even for months or for years. And you see here that compared to what we have seen for seropositive rheumatoid arthritis, the clinical picture is not becoming that milder, particularly for what concerns the patient-reported outcomes. That remains very impacting also in modern early arthritis clinic cohorts. So the patients suffer a lot, do have inflammation, and also suffer from chronic widespread pain that has already been established as a significant comorbidity in patients with seronegative rheumatoid arthritis. So we do have a diagnostic delay, and some English studies have shown and demonstrated that this diagnostic delay may arise from a number of factors, including the behavior of the general practitioner and the rheumatologist. So paradoxically, in seropositive rheumatoid arthritis, in which the clinical onset is probably milder, the greatest part of delay is the delay that the patient waits until going to the general practitioner, because the symptoms are not that much troublesome or impacting on the quality of life. In contrast, in seronegative rheumatoid arthritis, the onset is quite abrupt, so the patient seeks for help, but in the absence of biomarkers, so in the absence of rheumatoid factor and ACCP, the general practitioner probably doesn't trust too much and doesn't send the patient to the rheumatologist, and the rheumatologist himself, in the absence of autoantibodies, probably starts a lot of investigation to exclude other possible diagnosis, and so the diagnosis of seronegative rheumatoid arthritis is delayed and treatment institution is delayed, also because we erroneously think that seronegative rheumatoid arthritis is a kind of milder form and milder sister of seropositive rheumatoid arthritis. And in fact, we are not very much able to treat, and probably the tools and the drugs we do have for seropositive rheumatoid arthritis do not work that well also in the seronegative forms. These are data, very old data from, on the left part of the slide, from the Cimestro trial, which was a trial investigating the effect of intensive combination therapy of methotrexate plus cyclosporine plus high doses of glucocorticoids in patients with rheumatoid arthritis. This is, of course, is an old trial, but this old trial showed that this type of intensive therapy was better compared to the standard of care, so methotrexate only, in patients with anti-citrullinated protein antibodies, so the upper part of the panel, who benefited from intensive treatment, whereas the outcomes of seronegative patients were not modified by that intensive treatment compared to the standard of care alone. And again, we are analyzing data on the right part of the slide, coming again from our early arthritis clinic, in which we have changed our treatment protocol over the years. So before 2010, we started methotrexate in patients with rheumatoid arthritis at the initial dose of 10 milligrams per week, progressively increasing according to the treat to target strategy. After 2010, we have started giving the patient an initial dose of methotrexate of 15 milligrams per week, and we have seen that this change in the initial treatment dose of methotrexate was particularly of profit only for patients with autoantibodies. So the upper part of the slide, you see here that in red the new cohort, in blue the old cohort treated with lower doses of methotrexate. You see here that both low disease activity and remission are achieved more frequently when we start treatment with higher doses of methotrexate. In contrast, this change in therapy has not impacted at all the outcomes of seronegative rheumatoid arthritis that perform exactly the same irrespective of the initial dose of methotrexate. So let's say that seropositive rheumatoid arthritis is going to be more sensitive, so more responsive to methotrexate, and seronegative rheumatoid arthritis is a little bit less responsive to methotrexate, very similar to what we see, for instance, in psoriatic arthritis. A question arises on whether methotrexate is the right drug, the right starting treatment also for patients with seronegative rheumatoid arthritis. And also steroid and glucocorticoid co-medication may have a different effect. And again, here these are data that are being analyzed in our early arthritis cohort, showing that in patients with autoantibodies, so in aqua positive and rheumatoid factor positive rheumatoid arthritis, glucocorticoids, initial bridging doses of prednisone for 6 months, for instance, yes, do produce an effect in the achievement of the outcomes, but this effect is not that significant compared to methotrexate monotherapy alone. So probably at least a proportion of autoantibody positive rheumatoid arthritis can be dispensed from the combination therapy with glucocorticoids. In contrast, on the right part of the panel, patients with autoantibody negative rheumatoid arthritis do need glucocorticoids. You see here that the rate of the achievement of the different targets, low disease activity and remission, according to different criteria, is significantly improved by bridging therapies with glucocorticoids together with methotrexate. So glucocorticoids reinforces the effect of conventional synthetic DMARDs, particularly in autoantibody negative rheumatoid arthritis. This might be an idea. Much more robust, of course, are data on second-line therapies in rheumatoid arthritis. We have known for years that treatment that specifically target the adaptive immune response, such as rituximab, anti-B cells, or abatacept, anti-T-cell co-stimulation, are more effective in seropositive patients. No difference exists for tumor necrosis factor inhibitors, and still doubts exist on tocilizumab. So TNF work equally, apparently, in seronegative and seropositive forms. Tocilizumab has not that significant difference, whereas of course rituximab and abatacept are less effective in patients with seronegative rheumatoid arthritis, and observational studies have shown that no more than 30% of the patients with seronegative rheumatoid arthritis can go well on abatacept treatment. But again, here is a different also exists for drugs that we consider to be equally effective in seropositive and seronegative forms, because recent studies have shown that whilst in seropositive rheumatoid arthritis, TNF inhibitors should be given in combination with methotrexate, because this combination therapy prolongs the survival. These are survival curves that proxy and are a proxy of the efficacy, effectiveness, and safety of a drug, so drug retention rates. These retention rates are much improved by the combination therapy of the TNF with methotrexate only in seropositive rheumatoid arthritis. Whereas you can see, as confirmed by multiple studies, that apparently seronegative rheumatoid arthritis can be dispensed from the combination of a TNF with methotrexate. So TNF inhibitors can also be given in monotherapy. And this again very much resembles what we see in psoriatic arthritis, for instance, in which no clear differences exist in the retention rate of TNF inhibitors given in monotherapy. The response to biological treatment again might be a little different from in seronegative rheumatoid arthritis compared to the seropositive forms. Again, these are data coming from our early arthritis clinic that have been recently presented at an EULAR meeting and now submitted for publication, that show the retention curves of different line of biological therapies in patients started on a biological drug early, so within 3 years from disease onset, stratified for the presence of autoantibodies. And you see here that the retention of a first mechanism of action is approximately similar in seropositive and seronegative forms, but then, the retention, I've gone too quick, the retention to further lines of therapy is lower in seronegative patients. Another aspect, together with the problems in therapy, is that are we able to measure? So we do know what are the outcomes of seronegative rheumatoid arthritis. We consider, and we are used to consider, rheumatoid arthritis as a chronic disabling condition leading to joint erosions, progressive deformity, increased cardiovascular morbidity due to uncontrolled inflammation. Are these the same outcomes in seronegative rheumatoid arthritis, or is seronegative rheumatoid arthritis erosive? Does it increase cardiovascular event? Is it associated with extra-articular feature, or it is severe and impacts on patient's life for different measures that we do not still appropriately consider? So it is undoubtable that seronegative rheumatoid arthritis less severely affect the bone, both the joint structure and the systemic bone. We know that seronegative rheumatoid arthritis is generally non-erosive or less erosive, apart from those particular forms of severely distracting oligoarthritis of the wrists and of the shoulders. But in general, seronegative patients do not develop extensive erosive disease over the years. And this is true also for the systemic bone. Again, these are data coming from our experience showing that in patients with seropositive rheumatoid arthritis, systemic osteoporosis is a risk, Also, when the patients are appropriately treated with drugs, with conventional synthetic DMARDs, and with prevention therapies for osteoporosis, and this is probably attributable to a direct effect of autoantibodies on bone. You know that the anti-cellulated antibodies protein antibodies can directly activate osteoclast bone resorption. Joint erosion and systemic osteoporosis are not that a problem in patients with seronegative rheumatoid arthritis, so the bone is relatively spared. And again, the percentage of drug-free remission and response to therapy as considered and as measured by the composite disease activity indexes is rather similar in seropositive and seronegative rheumatoid arthritis. But what we do have in seronegative rheumatoid arthritis is persistent pain, chronic pain, and disability. So these patients suffer a lot, much more compared to those with seropositive rheumatoid arthritis, because we are able to treat, but predominantly because of persistent pain. And in fact, the relationship between pain and inflammation apparently slightly differs between seropositive and seronegative rheumatoid arthritis. These are data showing the dynamics of objective measures of inflammation and subjective components of the patient perception, showing that pain is much more linked to inflammation in seropositive rheumatoid arthritis. So there is a correlation between the level of pain and the level of disease activity in seropositive rheumatoid arthritis. In contrast, in seronegative rheumatoid arthritis, this correlation is very early lost. So the pain in patients with seronegative rheumatoid arthritis cannot be directly and only explained by the inflammatory burden of the patient, and you all experience in your clinics that despite the fact that you consider a patient with seronegative rheumatoid arthritis to be in remission because he or she has very low levels of swollen joints, very low levels of acute phase reactant, these patients continue to complain persistent chronic and disabling pain that is clearly uncoupled from inflammation. And in fact, the patient-reported outcomes, so pain, the patient global assessment of disease activity, impaired function, are our main obstacles in the achievement of good treatment targets in patients with seronegative rheumatoid arthritis that miss the achievement of remission according to our composite indexes, not because of persistent inflammation, but because of persistent pain. So a better understanding of the pain mechanisms in seronegative rheumatoid arthritis is really urgent, because these patients are severely affected, are disabled compared to those with seropositive rheumatoid arthritis, but predominantly because of persistent pain, not because of persistent inflammation. And here is to summarize a little bit the different paths in seropositive and seronegative rheumatoid arthritis. Again, we see that seropositive rheumatoid arthritis is a much more predictable disease in which we can identify a preclinical phase, and we can identify a starting point. We can expect and measure the response to methotrexate and to the other biological drugs. And when the patient is refractory to treatment in seropositive rheumatoid arthritis, he or she is refractory predominantly because of persistent inflammation, and this persistent inflammation, of course, leads to the classical consequences that we know. So leads to the inflammatory consequences of the disease, joint damage, systemic bone damage, increased cardiovascular morbidity and mortality, all the inflammatory driven consequences of the disease. In contrast, on the top part of the slide, the path of seronegative rheumatoid arthritis seems to be different and very poorly explored and understood compared to that of seropositive. We cannot really identify a preclinical phase, so also the preventive strategies that are becoming very popular in seropositive rheumatoid arthritis are missing in patients who do not have autoantibodies. So we do not know how and when the disease starts, and of course what are the causes and mechanisms, and we cannot try to prevent or alleviate the onset of the disease. The response to treatment once the disease is diagnosed is much more variable. We have seen that methotrexate might work better in seropositive rheumatoid arthritis. There are some biological that equally works in seropositive and seronegative rheumatoid arthritis, for instance, the tumor necrosis factor antagonists, with the note that they can be given in monotherapy in patients with seronegative rheumatoid arthritis. Other biological that of course work less in seronegative rheumatoid arthritis, for instance, abatacept and rituximab. These patients remain difficult to treat and refractory, but compared to patients with seropositive rheumatoid arthritis in whom persistent inflammation is the problem, so we do have to target inflammation. The major problem in patients with seronegative rheumatoid arthritis refractory to treatment seems to be persistent pain partially uncoupled from inflammation. There is a lot of debate in the world of rheumatology nowadays on whether this pain is a consequence of inflammation, so it is acceptable to improve through an increase of immune modulators because it has had an inflammatory basis, or if it is completely uncoupled, so if we have to perform a dual target strategy, so control inflammation and disease activity through our disease modifying anti-rheumatic drugs and approach the pain component through other systems, so psychological support, medication, analgesics, but not by increasing the dose or the type of immune suppressants. But pain and persistent pain is the problem in seronegative rheumatoid arthritis. So what are the take-home messages of my talk? Of course, seronegative rheumatoid arthritis is a diagnosis of exclusion. We do not know nothing on the genetic and environmental and pathophysiological background of seronegative rheumatoid arthritis, but we have the strong suspect that the seronegative forms can profoundly differ from the seropositive, and probably in the so-called inflammatory disease continuum, autoantibody seronegative rheumatoid arthritis might share some immunopathological features with other seronegative arthritis, including psoriatic arthritis. Unfortunately, all these poor knowledge of the seronegative forms of rheumatoid arthritis lead and are associated with significant diagnostic delay, and also to worse response to treatment at follow-up, because the effect of different medication differ in seronegative rheumatoid arthritis, and the outcomes are not achieved because of the persistence of some components of the disease that we are not still able to target. So seropositive and seronegative rheumatoid arthritis, I personally believe that these two subtypes should be separated and approached differently, but definitively more research is needed in seronegative rheumatoid arthritis to understand the best treatment approach, also based on advances in our understanding of the pathophysiological mechanisms. Thank you a lot, and I would like to thank all my collaborators in Pavia. You see a very big group, and thank you a lot for giving me the opportunity to give this talk.